Before we start, I'd be really interested if those people in the room who are currently innovating could put your hand up and keep your hand up for me. And those who do not have a clinical background, put your hands down. So that's more than 50% are not from a clinical background. So my background, just so you know, I'm Sandeep, Chauhan. I am a practicing orthopedic surgeon. 50% of my time is in NHS, 50% privately, and the other 100% is running a digital health company. That's why I'm grey. Any innovation must have a problem. And our problem, or my problem, was really, really simple. How do I get a patient into the operating room? Sounds pretty basic, right? On my very first day as a junior doctor, I had my white crisp coat, very proud. I had the job in the professorial unit at St. Thomas's. I walked up, led the professors up to the ward, to the first bed, which was empty. Not a great start, Miss Chauhan, not a great start, as my professor said to me. It was empty because the bed manager said he didn't have beds. I'm not going to go into the reasons why. But that cancellation left an entire team and 8 hours of empty operating time. Fast forward to me last week. I have 3 4-day operating lists a week. I operate on about 6 major cases on each operating list. My waiting list, my NHS waiting list is 42 weeks. I operate pretty hard. Every time a patient gets cancelled, I get psychologically really upset, primarily for the patient, because usually they're cancelled at the last moment, as happened last week. But actually, I actually get coronary artery spasm because I've lost 2 hours of operating time that I could have had somebody else operate on. And if you think about how the NHS works, we have this conveyor belt of patients in whatever specialty, and we only start addressing them at the last minute, which is what we led to trying to solve this problem. Why do we do that? I've never really understood it. So, my co-founder, Rosie Scott, another doctor, we have deep sector knowledge of what we do. I don't just mean the surgery, but the entire process, whether it be NHS or private, and what goes wrong. We live it and we breathe it all the time. And we wanted to come up with a solution. And we knew what the solution was, so in 2015, we decided we were going to build it, because nobody else would. Our managers wouldn't, our hospital wouldn't, we wanted to deal with it. So we spoke to some patients, gave them what we thought was going to be the solution, and they said, that's not what we want. And we thought, okay, well, you're wrong. Let's pick some other patients. Obvious answer. Well, actually, those patients then said we were wrong as well. So we actually researched 3,000 patients and actually realized what they wanted. And actually, if you think about what we're trying to do in this symposium today, transforming patient pathways, it is the entire pathway that patients are on. From the moment they first contact somebody, right through to when they finish their care. It's not me as a surgeon, that little bit of operation I do, it's the entire pathway. And in surgery, if you think about that entire pathway, if we're honest, and I mean honest, and a bit self-critical ourselves, the basic problem is, when we see patients, we actually don't engage them very well. We actually do, but actually, anytime you're about to be told, I'm going to insult you with an operation, you're actually quite frightened, and therefore you don't absorb information we're going to give you. So actually, you have increased levels of anxiety, you may not understand what I'm giving you, English may not be your first language. And then, when we send patients home, it's a bit like the umbilical cord's been cut. We say, well, actually, we'll see you in 6 weeks or 8 weeks. We'll see you in 6 weeks or 8 weeks. And actually, they're then left. And a tiny creak in the middle of the night means that they think they're about to die, only because they've just had an operation, when in fact it's just a tiny noise. We spend £2.6 billion a year on 30-day readmissions within the NHS. That's the readmissions, not just the people who come to A&E. It's a huge problem for us. Our manual processes, the ability of different people on that pathway to do or not do things correctly, means that we have really poor coordination to deal with patients to get them into an operating theatre, in my case. And therefore, for hospitals, We get delay cancellations, hospitals lose revenue, managers get upset, we get upset, and it's a fair amount of stress. And we've had lots of people talk about workforce. I am part of that workforce. We decided to come up with a solution. We call it a smart surgical solution, and this is pre-COVID. This is not a response to COVID. We started this way before COVID. And actually, it was designed to treat the pathway. And it's designed to treat patients before and after they came to hospital, so before and after the EMR. Sorry, the slide's going forward. So basically, the moment a patient contacts and is seen by somebody, they start being assessed. They have smart assessments that they can complete at home. They have education, optimization. So you no longer wait to optimize patients. You're doing it then and there. We can review and triage patients. I'm going to talk more about the virtual ward in a second, but the key thing is the pathway produces complete data sets. Two small parts. Something as simple as assessing and optimizing patients. We do not do it very well at all. The average reading of information we give to patients is 18 years old, whereas our national reading age is 11. We continue to give people paper that they don't read. If they read it, they don't understand it, and we expect them to. It just doesn't work. So what we did was say, well, actually, if you watch TV, you tend to understand it. So let's convert everything to digital media. Let's consumerize things to patient. So if you're coming in to have a procedure, the procedure is listed and all the relative information is delivered straight to you. By letting the patients drive information, by allowing them to deliver information from home, what that then does is what my dean of my medical school told me on my very first day. Let patients talk to you and they will tell you everything. It's absolutely true. So by them telling you everything, it means the knock-on effect is that when we look at what happens in the hospital, we reduce the time nurses spend by over 60%. So 100% of patients used to be seen face-to-face, up to 60% are now seen via telephone, whether it be public or private, whether it be in the Homerton, which is one of the most impoverished parts of London, or North Cumbria. Not necessarily impoverished, but a different population group. All that information is delivered into the EMR, Cerner, Epic, MedTech, etc. And interoperability is a key for you as innovators. If you don't have interoperability, so you can't deliver things into EMR via FHIR, and also if you can't have SSO going the other way to NHS app, my PKB, Zesty, the Wayfinder 1 program, you're dead in the water. So you've got to have continuous information. But then when patients go home, they need to enter a virtual ward. I don't like the word virtual because there's nothing virtual about this other than that patients are self-delivering the information to us. It's hybrid care. It means we as doctors can deliver care to patients by getting key information. The reason I'm keeping this up is this is Innovate UK. This was our idea, funded by Innovate UK. One of the biggest orthopaedic centres in London, they've used this successfully. And presented recently, won 3 HSJ awards. They've reduced their surgical site infection by 50%. They've reduced their readmission rate by 33%. They're a massive outlier nationally, and they're now one of the best outcomes of readmissions in the country. More interestingly, they put 400 hip and knee replacements through the virtual ward. They discharged 87% directly from the virtual ward. They then weren't seen again. That released 33 full days of hospital time. The outcome, 400,000 patients, 31 different sites up and down the country, public and private, engaged patients. They're incredibly engaged because they are driving the process. You have quite enhanced post-operative recovery. The physicians, us, doctors, like it because actually everything is optimized for the patient health. And actually, we have enhanced outcomes. So for innovators out there, all sounds great, right? The problem is you need evidence, and you need lots of it. And evidence doesn't come overnight, so you have to build it up. And I want to touch on a few bits of evidence because other people don't necessarily talk about it. The first is an interesting thing called real-world economic validation. Now, I've done lots of research in my life, and this is a new one on me. But the reason I say that is there's two parts to this. The first is the 70K underneath, it's expensive. Okay, this is independent. So Unity Insights, KSS Deanery, or sorry, KSS Hindau, I think it is, independent, worked with them to do all the independent analysis. You have no sight of it until they've published it. This particular study was done at Royal Surrey County, sponsored by NHSE and the Office of Life Sciences, SBRI. What's really interesting about independent economic analysis is if you do anything good, they follow HMR Treasury rules and they dampen it by 20%. If you do anything bad, they say it's even worse and they uplift it by 20%, which doesn't sound fair. But actually, I can understand then that the results must be pretty valid, right? There's no bias. So they had a previous digital solution which wasn't working very well, and this comes down to digital transformation, and we went in and basically within 4 weeks of transferring from a paper pathway to a digital pathway, 99.5% of every surgical patient went through the pathway. The DNA rate dropped to 0.6% from 7%. You can see the rest in terms of reduction of face-to-face appointments and high patient satisfaction. From an economic point of view, we save £1.94 million. So per 200,000 patients a year, that equates to 8.7 million, of which 4-ish is cash releasing, according to that report. So for the innovators, that's great. You're showing your economic value to go to the CFO or the CEO and say, look, we can save you money, and the clinicians want it. The downside is NHS attitude. So for example, some CFOs, quite truly, have said to us, well, which nurses can we sack? At which point you say, we don't have any, really. What you're doing is creating capacity in a system that has no capacity because we have no staff. So there's a reality around the reactions that you get. I talked about evidence. There's lots of evidence that we produced. Provider efficiency, care delivery, reducing workload, reducing staff inefficiencies, reducing pressures. You have to produce evidence as an innovator to get your innovation adopted and to transform pathways going forward. But innovation doesn't change. Alex gave a great talk about structured and unstructured data. I'm not going to go into that, but actually from what we've done, we now have 400,000 structured data records, pre-surgery and most importantly, post-surgery. Because the surgeons, what we're interested in is how do we improve the outcomes? How do we make you better? So why is it that a left hemicrectomy in one hospital has a 3% readmission rate and another hospital a 17% readmission rate? What is it? Is it just the surgeon? The surgeon blames the patient or the hospital. What's the truth behind it? Well, we can now say, actually, that we can start predicting what's going to happen to patients pre-surgery based on their post-surgical outcomes. Okay? So you can start taking patient health before they have surgery and start predicting what's going to happen after surgery. What's more interesting is you can weight that, and then during surgery, what's really, really interesting is you can look at subtle variables. So I'm happy to show you this because this is my surgical data, so I can share my things with you. And basically, 2 millimeters difference in how I do a knee replacement can put a patient between the best outcome group and the worst outcome group. We're talking millimeters. And this is how precision medicine will change surgery with large volume data sets going forward, not just in my world, but in any form of surgery going forward. And the final piece of the puzzle is the post-operative virtual ward. I come back to Innovate UK, believing in us, giving us our grant, enabling us to do this. What we found in outcomes is we measure outcomes at 6 months, 1 year, etc. But if you look at the first 6 weeks following surgery, if you have poor pain and poor mood, you're in the worst outcome groups in the long term. And actually, you can figure out who's going to have poor pain from actually the variables you have during the collection of doing during data. So a good clinical tool is providing you with good clinical data. Despite all this exciting stuff, we have the NHS. And as our previous speaker said, there is not one NHS. There are lots of NHSs of different sizes, shapes, etc. And there are various blockers. And actually, I disagree with one of the talks earlier on, which is it's not the clinicians. The biggest blockers we've found is IT and actually finance. The two biggest things. Despite having complete interoperability, you still have a blocker there. But you can make a difference as innovators in terms of transforming pathways. 3 different hospitals 7 different awards. So range from the Virtue Award, Sweddock Big Orthopaedic Centre, Royal Surrey on the right-hand side, the NHS Partnership Award. Probably the proudest is the Green Award at the bottom, the NHS Green Award, because by transforming the digital pathway, we've reduced carbon significantly more than any other technology that's currently available. So if we can do this across the country, we can make a significant impact on what is one of the biggest carbon delivery things in surgery going forward. Thanks for your time.
The Harley Street Health District, the home of healthcare since 1860.